Hello, everyone. Welcome to this session of our global classroom. Today, we will be discussing chronic pancreatitis. I am Dr. Philip Thomas. I'm a surgeon specialized in liver, biliary, pancreas, and transplant surgery. And as you can see from the slide, I've had a long journey in medical education. I had my own initial medical education in India, and then I was teaching in India, where I became professor of surgery at St. John's Medical College, and I was examiner at the MBBS, MS, and DNB examinations. And subsequently, I moved to the US, where I presently live, and I was an associate professor with tenure at the University of Texas at Galveston, and subsequently at the University of Texas, the Rio Grande Valley. What are the objectives of this class today? The first thing is, I want you to be able, with some degree of confidence, to be able to make a diagnosis of chronic pancreatitis. I want you to be able to distinguish this from acute pancreatitis, complicated by certain things like fluid collections or infections or thrombosis that tend to be chronic. However, they're still part of the acute pancreatitis spectrum. The next thing I want you to understand or appreciate is the value of classification in pancreatitis, acute and chronic. And finally, I want you to be able to have an idea of how to manage this condition. Now, before we go further, don't forget that management is basically two things: investigation and treatment. And when it comes to investigation today of the pancreas, there is no limit to the number of investigations you can do. You can start with ultrasound, go on to CT scan, MRI scan, you can order endoscopy, ERCP, endoscopic ultrasound, fine needle aspiration. It goes on and on and on. And what happens as a result of it? The patient goes from one investigation to another, to another, to another, getting all kinds of information, sometimes contradictory information, losing confidence in the entire system. So I want you to be able to exercise good judgment in how you order and plan the investigations of this condition. Again, when you come to treatment, there are a whole lot of options today which were not present just barely 20 or 30 years ago. And you have various specialists who are able to help with the management, whether they're interventional radiologists, advanced gastroenterology endoscopists, or surgeons. So to be able to direct the patient to the right person for the correct treatment is an essential part of having the confidence of managing chronic pancreatitis. Lastly, I want you to have some idea of the research possibilities, what you can do going forward if you have in your mind the idea that here is a condition which can be publishable, which can be researched, and you can go into the molecular and the genetics of this condition. You will also learn something unusual, perhaps, about diabetes and the approach to diabetes of a surgeon, especially a surgeon who has done a lot of pancreas transplants. What is the global incidence and prevalence of chronic pancreatitis? Well, there's good news and there's bad news. The good news is that the incidence is coming down. This is one of the few diseases where the incidence is actually decreasing. The bad news is you can't make a living treating chronic pancreatitis. If you look at this slide, you will see that the incidence of acute pancreatitis is 4 to 8 times that of chronic pancreatitis today, as is the prevalence. The bottom line of this is that chronic pancreatitis today is less of a clinical problem than acute pancreatitis. And what is more interesting, though, is that chronic pancreatitis is a spectrum of disease that can merge into or be difficult to distinguish from carcinoma of the pancreas, which will be our next topic. It is interesting to speculate on why the incidence of chronic pancreatitis is coming down. The incidence was very high in the middle of the last century. You have to remember that the last century saw two world wars. If there was malnutrition, it was usually undernutrition. All that has gone away. Now our problem of malnutrition is overnutrition. And the overnutrition leads to more of acute pancreatitis than chronic pancreatitis, which is what we saw a lot of in the late 20th century. The definition and the clinical triad of chronic pancreatitis. Remember, whenever we use the word chronic, it means two things. Clinically, it means there is going to be a loss of function, and histopathologically, it means that there is going to be fibrosis. So the definition of chronic pancreatitis, a progressive, destructive, chronic inflammatory condition of the pancreas associated with atrophy of the gland, which is then replaced by fibrous tissue. The clinical triad, which distinguishes chronic pancreatitis, is three things. Loss of exocrine function, which means malabsorption and weight loss. Loss of endocrine function, which means diabetes, and pain. I mentioned pain last of all because there are several people with chronic pancreatitis who do not present with pain. They may say, when you investigate or ask a good history, that they had a few episodes of pain in the past, which got treated as ulcer disease or whatever. And now the pain has gone away, but the progressive, destructive, inflammatory condition, which has replaced the pancreas with fibrous tissue, and there is no acinar, no exocrine function left, that is why the pain has gone away. That leads to the question, why do these patients have pain? There was a time when we thought that the pain is because of an increase in the pressure within the pancreatic ductal system, because very often there are stones seen in the pancreatic ductal system. Well, guess what? All of us were so keen to drain the pancreatic duct. Doctors love draining things. Unfortunately, the pain is not always due to increased intraductal pressure. There is definitely a component of nerves or ischemia of the nerves where the fibrous tissue in the pancreas and around it entrap these nerves. The pancreas is surrounded by a rich supply of autonomic nerves, the parasympathetic system, the celiac ganglia, the superior mesenteric ganglia, and all of them mediate pain, which is then referred to some somatic nerve distribution and results in the severe, typical chronic pancreatitis pain, which is in the epigastrium and radiating to the back. I want you guys that we're going to talk classification. Why do we need classification? Think of it, you're classifying things all the time. Let's say you see something flying in the sky. How will you classify this? Let me tell you how your brain processes it. The first thing you will see is this an animate object or is it an inanimate object? If it is animate, is it flying, flapping around, or is it leaping? If it's leaping at you, you need to run from there first. There's no further time left. If it is an inanimate object, you want to think, is it metallic or is it non-metallic? Okay, it's metallic. Now, is it propeller driven or is it jet driven? Is it going in one direction or is it darting back and forth? Is it a plane? No. Then, is it a UFO? That is what your mind goes through whenever you see a flying object. The same way we classify things in medicine and surgery almost involuntarily, automatically. We can bring this concept to pancreatitis, acute and chronic. Not many people today talk about the Marseille classification. The Marseille classification was done twice, once in 1964 and once again in 1984. When you think of those two eras in medicine, you have to remember that most of what we had was good clinical diagnosis. Ultrasound was just starting. There was hardly anything known as CT. Forget about MRI. ERCP, few centers did it. So most of the classification that came out of Marseille was what we call a clinical pathological correlation. In other words, we were taught to think that from the clinical picture of a patient, we could predict the pathology of the pancreas gland itself. The basis of the Marseille classification was that pancreatitis is basically one of two types, either acute or chronic. Acute generally tends to stay acute, and chronic may have started as chronic, or at least when you see it, it's already chronic. The overlap of acute going on to chronic did occur, but in a minority of patients. Acute pancreatitis could have periods when there were no symptoms, and you would call it acute relapsing pancreatitis. The point to be noted was that in between the acute episodes, the pancreas was more or less functionally normal. On the other hand, in chronic pancreatitis, you could get symptom-free periods. So it would be chronic relapsing pancreatitis, but functionally the pancreas would never be normal. Once again, remember that the only investigation that was available all over the world, especially in the regions where chronic pancreatitis was endemic, was the simple, straightforward, plain X-ray of the abdomen, or what we used to call the KUB, the kidney ureter bladder film, because the penetration was enough to show you structures at the depth of the kidneys, which means the pancreas could be seen. And all that we looked for was calcification in the pancreas. My contribution to chronic pancreatitis from an endemic area in Kerala, in India, was that I started doing operative pancreatograms in these patients who required surgery because of pain. So I would expose the pancreas, stick a needle into the duct, shoot the dye, and demonstrate ductal anatomy. Subsequently, people didn't have to get operated for this when ERCP and MRI, MRCP, all of these investigations came along, and it's possible to delineate the ductal anatomy without operating on the patient. Once again, going back to the clinical pathological correlation, in the acute pancreatitis spectrum, you have a swollen, edematous, angry parenchyma of the pancreas, and the duct is not dilated. In the chronic pancreatitis, you have a fibrotic, atrophic, shrunken pancreas that can be barely distinguished, and the duct is characteristically dilated, and there may be stones within the duct. Calcification plus fibrosis equals chronic pancreatitis. Moving on to the clinical features. Remember the triad: loss of exocrine function, loss of endocrine function, and pain. Let's start with loss of exocrine function. What happens when there is no pancreatic juice? Fats, proteins don't get digested. Therefore, they pass all the way through, and you get very fatty, foamy stools that float, and you get all the deficiencies of the fat-soluble vitamins. With protein, malabsorption, malnutrition, the patient loses weight. So weight loss with large, bulky, greasy stools is a characteristic of loss of exocrine function of the pancreas. What happens when this typical history is not available? Well, you can do tests. Fecal fat, fecal elastase. But guess what? You need to collect 3 days of stools. Not every lab wants to do this test, and not every doctor or patient wants it either. You can get very unpopular with your lab and with your patient by ordering 3-day stool fecal fat. Most of the time, and in most of the labs, this test is not available to be done. Number 2 in the clinical triad: loss of endocrine function. I'm going to dwell a little bit on this diabetes. Bear with me. I'm a surgeon. You're going to learn something about diabetes from the viewpoint of a surgeon, especially one who has done a lot of pancreas transplants. The diabetes in chronic pancreatitis is not because there is a deficiency of the beta or alpha cells in the islets of Langerhans. It's because the gland has been replaced by fibrous tissue. There is very little blood flow into and around the islets of Langerhans. And so there is no insulin and there is no glucagon. What happens? The diabetes becomes very brittle. There will be spells of severe hypoglycemia. Now you might ask, how is this any different from type 1 diabetes? Type 1 diabetes, you can get severe hypoglycemia as well. However, the only way you can get severe hypoglycemia in a type 1 diabetic is when diabetes has gone on long enough to completely blow out the autonomic nervous system. You can get peripheral neuropathy, you get autonomic neuropathy, as a result of which the patient cannot appreciate when his blood sugars are dropping as a result of the insulin that he took to treat the high blood sugar. And therefore, they go into severe hypoglycemia. This doesn't typically happen in pancreatic diabetes because the autonomic nervous system is intact. These patients don't have severe postural hypotension when they stand up. They don't have problems emptying their bladder. They don't have problems with gastric atony. They just have brittle diabetes. One little word here which you can learn: nesidioblastosis. You may have heard of severe hypoglycemia resulting from insulinomas of the pancreas. What happens, especially in children who are born with hyperinsulinemic syndromes without a tumor that you can call a hyperinsulinoma tumor, you can get diffuse excess of islets of Langerhans in the pancreas, and this is called nesidioblastosis. So in a child with severe hypoglycemia, you have to diagnose, is this due to an insulinoma or is it due to nesidioblastosis? The treatment, as you can tell, will be very different. In an insulinoma, just take out the insulin-producing tumor. In severe nesidioblastosis, you have to do a pancreatectomy, a whole different approach. Well, in chronic pancreatitis, the fibrosis brings all the islets together so that in one frame of the slide, if you were to do a section of the pancreas and look at the slide, you get what looks like nesidioblastosis. However, this is not true nesidioblastosis, this is pseudo-nesidioblastosis. Number 3 in the triad, pain. I touched on pain earlier in terms of the mechanisms of the pain, ductal hypertension versus nerve entrapment. Whatever it is, pain can be very severe in several of these patients, and it becomes a way of grading the severity of the chronic pancreatitis. If the pain is relieved by simple Tylenol or paracetamol, then that's the easiest or the lowest grade. The moment narcotics are required, tramadol may be the next, and finally, opioids. Patients who need long-term opioid analgesia are often only manageable by people like the palliative care service who can give long-term opioid medications without attracting the adverse attention of the regulatory bodies that monitor opioid prescriptions. The pain of chronic pancreatitis can overlap with the pain of carcinoma of the pancreas. We will be dealing with cancer of the pancreas at a subsequent session, but this is something that has to be remembered, especially when the fibrotic process in the pancreas starts involving adjacent structures, like the bile duct causing a bile duct stricture, or the duodenum causing gastric outlet obstruction, or the splenic vein, which then results in splenic vein thrombosis and left-sided portal hypertension. Also a topic for further discussion down the road. But these extrapancreatic involvement by the fibrotic process can cause pain and a whole host of symptoms related to that rather than the pancreas. Physical findings, not much. You just have to remember the basic morphology of the patient, the phenotype, in other words, the acute pancreatitis phenotype, generally big, robust, overweight person. The chronic pancreatitis phenotype, which is malnourished, underweight, and bent over with severe pain going into the back of the pancreas. Again, maybe hard to distinguish this from disseminated or advanced pancreatic cancer. Etiology of chronic pancreatitis, essentially most of the patients are due to alcohol or tobacco. So they're classified as toxic etiology of chronic pancreatitis. You will find in some of the books this little acronym called TIGAR-O, TIGAR-O. The acronym stands for toxic, idiopathic, G for genetic, A for autoimmune, and R for recurrent pancreatitis secondary to ductal obstruction, which, as you might remember, I told you is not common. A word about the genetic component of the etiology. We know now that it is possible to do genome analysis and find out the gene that is responsible for disease. Analyzing the whole genome at one point used to cost up to $50,000 per patient. If you have a patient who is on the younger side, who doesn't have a long history of alcohol, smoking, none of those things that cause toxic etiology for chronic pancreatitis, you need to start thinking, is this patient part of a familial cluster, in which case there is a gene going in the family, or is it a mutant? Here are some of the genes that are associated with diseases of the pancreas. The PRSS gene, the PRES gene, codes for the protein that is involved in trypsinogen. So obviously, it's going to be relevant to the pancreas. It is actually associated with acute pancreatitis, but it is also found in carcinoma of the pancreas. You have the SPINK1 gene, which has been related to tropical pancreatitis. CFTR and CTRC are pretty specific genes found in pancreatic diseases. CASR is a gene associated with familial hypercalcemia. Remember, if the calcium is high, you shouldn't miss that. There is no reason for the calcium to be high in a patient with either acute pancreatitis or chronic pancreatitis. If anything, the calcium should be low. If you're talking about autoimmune causes of pancreatitis, usually autoimmune diseases are not single organ diseases. There will be stuff going on in other organs. When it comes to autoimmune, look at the skin, the kidneys, the joints, and when you have a multi-system involvement, then you can start thinking in terms of an autoimmune etiology in this patient. Lastly, ductal obstruction. This is the one diagnosis that all clinicians are waiting for, because this is easy to relieve either by endoscopy or by surgery, and then you can take credit for having solved the whole problem. But like I said, very rare. Remember, we talked about investigations, imaging, and the huge spectrum of imaging options that are available today. It is important to pick the right investigation. I have a little trick that I've used with my residents. I tell them to take a bet on what the investigation is going to show. $10 that there's going to be a dilated pancreatic duct, or $10 that this is an acute pancreatitis with no duct, just a big swollen gland, or an autonomic pancreatitis which has got a sausage-shaped pancreas, swollen, hardly any ductal dilatation, and we're waiting for the IgG4 to come in. What is the purpose of taking bets and trying to guess what the investigation will show? After some time, you will become confident in correlating the clinical picture and the imaging findings, so that down the road, you won't be telling your patient, oh, I'm going to order an MRI scan and see what it shows. You're going to be telling the patient, I think you have chronic pancreatitis, and I'm ordering an MRI scan to see if you have got a fibrotic gland and a dilated duct. Believe me, it makes a big difference to the patient, because now he knows what you are looking for. He's not at the mercy of an unknown institution or establishment where he goes to get his MRI scan done. Whatever imaging findings that come in, whatever imaging modality you choose, remember there are essentially two things that you're looking for: findings that are focal or findings that are generalized. Focal findings can be cystic lesions, can be fibrotic lesions, can be inflammatory phlegmonous lesions. Diffuse diseases will be atrophy, scarring, dilated pancreatic duct. Moving on to management. Remember, this patient has a chronic disease. This disease is not going to go away as long as he's alive. This patient doesn't need a fixer. He needs a partner. If you can partner with this patient, help him to make lifestyle modification, help him to lead the best quality of life that is possible with a disease that's not going to go away. This will be your best patient, your advocate for you being a good doctor to his entire community and neighborhood. You have to do surveillance for complications, for cancer, for all this sort of stuff, and you have to make a choice of investigations. As you partner with the patient through this, you can be the one then deciding, does he need to be referred to an advanced gastroenterologist to do some endoscopic procedure? Does he need surgery? Gastroenterologists do a lot of endoscopic procedures. But when it comes to dealing with the pancreas endoscopically, that is a little more nuanced. It's better to have these patients referred to somebody who's doing a high volume of these cases. Draining a pseudocyst in an acute pancreatitis situation via an endoscope is relatively easy because the pseudocyst applies firmly to the back of the stomach wall, and the fibrosis element is such that you're not going to get leakage of the pancreatic juice elsewhere other than directly into the stomach. When it comes to chronic pancreatitis, these cysts are not closely applied to the back wall of the stomach, and therefore dealing with them endoscopically can be tricky. Stenting the main pancreatic duct, removing stones from the main pancreatic duct, combining this with lithotripsy, these are all procedures which have to be done in high volume centers and by endoscopists who are dedicated to this kind of work. Talking about fine needle aspiration, this is an even more involved problem because to do reliable fine needle aspiration, you have to have a correlation between the gastroenterologist who's doing the endoscopic procedure and the pathologist who's going to come and look at those slides immediately. Preferably, the pathologist should be in the room so that they look at the specimen and they tell the endoscopist immediately, is this adequate or is it not adequate? The worst thing that you can do to a patient is say that there was a mass, we did an FNA, but the result is inconclusive. And therefore, we don't know whether you need to be referred to a surgeon to excise it, or we just keep watching and doing more imaging and endoscopies down the road. Remember the word predictive value or positive predictive value. It is not possible for any single test to be given the entire importance of diagnosis. You cannot hinge the diagnosis on one test. You have to be like the detective who is gathering evidence based on clinical features, evidence based on imaging, and then finally evidence based on the cytology or biopsy. Saying that one of these is going to be the whole diagnosis is not correct because no test has got 100% positive predictive value. The way to understand sensitivity, specificity, and predictive value is a topic for another day and maybe for a statistician. In the past, the only way of tackling many of these problems in the pancreas was by interventional radiology. Now, a lot of them can be done by the advanced gastroenterologist. There is one area, however, where the interventional radiologist is still required. That is, when there is a long stricture of the lower end of the bile duct and the endoscopist can't get his ERCP stent in place. And this, I will draw a diagram for you to understand better. Just to show you briefly what is ERCP or endoscopic retrograde cholangiopancreaticogram. You have the stomach, esophagus, and the stomach. The endoscope is introduced into the stomach. Then you turn it and you bring it into the duodenum. And it comes down to the second part of the duodenum. In the second part of the duodenum is the ampulla of Vater and the pancreas can be visualized. This pancreatic duct can be cannulated. Shoot dye in there and you get a pancreatogram. The main pancreatic duct should be no more than 2 to 3 millimeters in diameter. If the pancreatic duct is dilated, this is a sign of chronic pancreatitis. If there are stones inside, even more confirmatory of the diagnosis. Side branches may or may not be involved, but if the side branches become cystic, then it's an even more severe form of the chronic pancreatitis. What happens if the fibrotic process here in the head of the pancreas involves the common bile duct? What you will get is the bile duct entering the pancreas on its way to the duodenum, and this fibrotic process will cause a dense, long stricture of the CBD. Your ERCP scope comes here, and the cannula has to go upwards and backwards all the way up here to inject the dye and get a cholangiogram. This may be technically very difficult if the stricture is tight, and the only way you can then demonstrate the length and the characteristics of the stricture is to request the interventional radiologist will have to stick a needle in here and do a percutaneous transhepatic cholangiogram, or a PTC. And this can be followed by a percutaneous transhepatic biliary drainage to relieve the jaundice due to this long bile duct stricture. The problem comes when you have a long bile duct stricture to determine whether this is purely due to fibrosis or whether there is a tumor. And if you have an endoscopic ultrasound, it can look directly at this region and do FNA of this part of the pancreas, which may tell you if this is a benign stricturing process or if it is a tumor. If the FNA is inconclusive, you may have to just repeat imaging at 3 to 6 month intervals and add tumor markers to determine whether this is a stricture process or a tumor. If it is a tumor, the only way you can treat it is to resect it. And sometimes, when it's not possible to make out whether this is fibrosis or tumor, you may have to resect it anyway. And that resection is called a Whipple resection. And this will be dealt with in greater detail when we discuss cancer of the pancreas. What is required in benign conditions, however, is drainage. Moving on to surgery. There are essentially two operations that are required for chronic pancreatitis. One is drainage of the pancreatic duct. The second is resection of the pancreas. I will draw diagrams to show you what kind of operations we commonly do in chronic pancreatitis. Operation described for chronic pancreatitis is also called the pusto, or the lateral pancreaticojejunostomy. What is done in this is you have the pancreas with the dilated duct. This is the duodenum, and you have the pancreas, maybe some stones sitting inside the duct. You have to make an incision, find the duct, make an incision over it, and open up the whole pancreatic duct. Take a loop of jejunum down here, and swing it over the pancreas. Do a jejunostomy. So this is lateral pancreaticojejunostomy and jejunostomy. This operation is called the Pusto. Other drainage procedures that may be required are the gastrojejunostomy for gastric outlet obstruction, choledochojejunostomy for bile duct obstruction, and in the case of left-sided portal hypertension due to splenic vein thrombosis, the treatment is splenectomy. In conclusion, you may never see a patient with chronic pancreatitis, but understanding the concepts and the different opportunities that come in the form of genetic analysis, management of diabetes, management of these patients when you do get them is, I think, a good exercise in helping you to form a good global idea of the approach to diagnosis at this time in this modern era. Future surgeons, you will see chronic pancreatitis, but more in the context of pancreatic cancer. And this is something that we will discuss down the road. Once again, I encourage you to collaborate. Collaborative learning is the best way of learning. You can comment below this, or if you don't like doing that, you have my email address. I'm showing it once again here so that you can email me with questions that we can discuss. Don't forget the prize for those questions that have stumped you and that you think may stump the examiner. I'll sign off with the usual advice. Travel together to travel long, and stay in touch.